it was invaluable to have a psychologist as part of that team. Will discover things about an individual patient and their family dynamics that I would never even think to ask about in the clinic. And so that's why a multidisciplinary or team approach, your asthma educator, a savvy doctor, and having a psychologist available can really make a difference in these severe asthmatics. There was one child about 10 or 11 years old that we knew had severe asthma, but his mother had an anxiety disorder and would not report to his mother when symptoms were worsening because they didn't want their mother to become upset or worried. And I thought, oh my gosh, I would never have guessed this. And so that's why the patient tries to struggle through until they can no longer do so, and then it becomes an urgent matter. And so having the psychologist as part of the team, as I said, was a real eye-opener for me. No amount of medication was going to help because the patient would not ask for a lifeline, would not put their hand up, would not call for help because he or she didn't want to upset mommy.
Welcome to Beyond the Wheeze, the podcast where perseverance meets potential. I'm Josh Realm, public speaker, marathon runner, asthma advocate, and your host as we explore the intersection of health, fitness, and resilience. Whether you're managing asthma, chasing a new personal best, or simply looking for inspiration, Beyond the Wheeze is here to show you that no challenge is too great to overcome. Together, we'll uncover stories, insights, and strategies to help you push beyond your limits. It's time to breathe deeply, move forward, and unlock your true potential, one step at a time. Today, I had the distinct privilege of welcoming Dr. Paolo Pianosi to the show. Dr. Pianosi is a recently retired pediatric pulmonologist whose career has spanned decades and continents. Born and raised in Northern Ontario, he earned his MD from the University of Toronto, completed his pediatric residency at the University of Ottawa, and pursued a pediatric respiratory medicine fellowship at McGill University in Montreal. His professional journey led him to the IWK Health Centre in Halifax, Nova Scotia, where he served as an associate professor at Dalhousie University. It was during this time that I had the privilege of being under his care as a child and as a young adult. Dr. Pianosi's career continued at the Mayo Clinic in Rochester, Minnesota, where he achieved the rank of full professor in pediatric and adolescent medicine. After a brief tenure at King's College Hospital in London, he returned to the US and served as a professor of pediatrics at the University of Minnesota until his retirement in 2024. His research focused on respiratory physiology, particularly the physiology of exercise. He also contributed to the field as an associate editor of the journal Pediatric Exercise Science. Today, we'll reflect on his illustrious career, discuss advancements in pediatric pulmonology, and explore the importance of patient and family education in managing chronic respiratory conditions. With all that being said, Dr. Pianosi, welcome to Beyond the Wheeze.
Well, thanks, Josh. Thanks for the kind introduction, and I'm ready to answer your questions or freewheel.
So great to have you on. Dr. Pianosi, your career has taken you across Canada and the United States. Looking back, what moments stand out as particularly meaningful or impactful in your journey?
You know, even before I retired, I realized that, yes, I had a wanderlust. And I would never become an emeritus professor at any university because I didn't stay long enough. But the beauty of this peripatetic tendency that I had was that every place where I worked had different clinical problems encountered frequently. I started at University of Manitoba, and we saw a lot of poorly described lung disease among First Nations children. Then I went to Dalhousie, and that was similar to where I trained in Montreal, where we dealt with kids with asthma, cystic fibrosis, and the ex-preemies who had lung issues. When I went to Mayo Clinic, Rochester, I started to see patients and problems that previously I had only read about. So that was a real eye-opener. It forced me to become a student again, essentially, to learn things that I had learned once and forgotten because of never seeing the issue subsequently. King's College Hospital in London was again an eye-opener. I saw patients with sickle cell disease whom I hadn't seen since I did my fellowship at McGill. And asthma is a big problem in the UK, and it made me take a hard look at asthma and its management, particularly because we're in the 20 teens now in the area of biologic therapy, which I think we'll talk about later in the discussion. So, to summarize, yes, I wandered all over, but every place had its challenges. Although I was always a pediatric pulmonologist, it was a different patient population. And University of Minnesota is a huge transplant center, and I saw patients with lung complications due to solid organ or bone marrow transplantation. Big issue.
Having cared for countless children and adolescents, how have you seen the field of pediatric pulmonology evolve over the years?
I would have to say in hindsight that the biggest steps forward were made in the realm of cystic fibrosis. In terms of asthma, we had good drugs to manage asthma by the dawn of the new millennium. But it took another 10 years, at least maybe 20 years, before we figured out how to use those drugs properly. And if I look back retrospectively, I remember speaking with one of the representatives of a company that marketed a particular asthma medication. And I said to him, I find myself reaching for your combination puffer as first-line therapy instead of starting with an inhaled steroid alone and then advancing or escalating therapy depending on the situation. And his response was, "What's the matter with that?" Now, he may have been motivated by sales of their new product, but ultimately the study was done in the early part of the 2010s, compared inhaled corticosteroid alone with inhaled corticosteroid plus a long-acting beta agonist, such as Salmeter. And the reality was that asthma control was as good if you use the combination product as it was compared to doubling the inhaled steroid dose. Now, that was a landmark study for me because I always wanted to keep the dose of inhaled corticosteroid in children down as low as possible. Just so we're clear, and for the audience, inhaled corticosteroids are safe drugs. They are not like oral steroids that have significant adverse or side effects. Inhaled corticosteroids are well tolerated in low doses. And so if you can keep the dose low and add a second drug, particularly if it's combined in a single puffer, then the patient will have better asthma control at a lower total daily dose of inhaled corticosteroid. And in fact, the field has moved from there to what's called SMART therapy. Now, SMART, S-M-A-R-T, is an acronym for Single, Maintenance, and Reliever Therapy. And in this treatment regimen, you combine an inhaled steroid with a long-acting bronchodilator, something that albuterol or salbutamol does, but it lasts 12 to 18 hours. And that's the so-called combination product that I found myself reaching for back in the late 90s. And with SMART therapy, studies have shown that in patients with mild asthma, their control is as good, meaning they have fewer ER visits, fewer exacerbations, fewer times they need oral corticosteroids if they use their combination puffer as needed. Now, that was really revolutionary, and I'm still not sure, it doesn't sit right with me, but I'm retired now, so I don't have to deal with it. But for decades, literally, we were telling patients you have to take your inhaled steroid every day for it to be effective. You cannot take it only when you need it because it will not work that way. But with SMART therapy, because the patient is receiving their inhaled steroid, which, as you know, is the preventer medication, and a long-acting bronchodilator, which is a reliever medication, the patient feels the symptom relief because the bronchodilators work, but with the same puff, they're actually getting their preventer medication, their inhaled corticosteroid. And with SMART therapy, you can take your puffer up to 2 puffs 4 times a day. Some of my colleagues will say 2 puffs 6 times a day. And what studies show is you achieve similar asthma control to daily use, but over a 12-month period, you will use less medication if you use the SMART protocol as opposed to taking it every day regardless of how you feel. Now, having told patients they have to take it every day for the better part of 30 years, I'm a little hesitant to say you can just take it as needed, because it runs counter to what we've been saying until, the last 5 years. But it seems to be working. And in fact, that's probably the future of asthma treatment for most asthmatics. And we can talk about the more severe asthmatics later on. But this therapy intuitively makes a lot of sense, because we know from pharmacologic and prescription refill studies that probably only 35 or 40% of their patients take their asthma medication as prescribed, and the rest don't take it. When they're feeling fine, they skip their puff or they forget. They think, they rationalize it. I'm doing okay, so I don't need it. and then an asthma flare-up occurs, and if they have only a bronchodilator available, they have to go to the ER, and they often get oral corticosteroids. Whereas with the SMART therapy, if they were to reach for their combination puffer, which remember has both a preventer and a reliever, they'll get both drugs that they need, and they may not need to go to the ER. They may not require a dose of oral corticosteroid. And that's the rationale behind this form of treatment.
I had Dr. Alan Kaplan on last week as we kind of discussed, and he mentioned that as well. He said, it's human nature that when we feel better, we don't take our medication, but it's important to note that asthma is not episodic. It's a chronic illness. And I'm pretty sure I'm on one of these inhalers that you're talking about. I won't say the name, starts with a T, but it's been rather recent for me. And it's exactly like you said. And I find it helps me so much now, short of a biologic for myself. I can guess that that's probably the best I'm going to get.
Probably. I mean, I used to, and this may be one of the questions you were going to ask me later, but I used to say to parents, well, you have high blood pressure. You feel fine until you have your stroke. Are you going to start taking your blood pressure medication once you've had your stroke? And every parent says, well, no, of course not. I don't want to have a stroke. Well, if you approached asthma the same way, you would take your daily preventer therapy or your SMART therapy, knowing that the whole premise behind that treatment is to prevent the stroke, meaning prevent the ER visit and the need for 3 days or 5 days of oral, or 7 days of oral corticosteroids. And so that's the analogy I use when I explain to parents. I'm not sure it sinks in, but it makes a lot of sense. I mean, everybody says, no, I don't want to have a stroke. I'll take my blood pressure medication, but we got to approach asthma the same way.
Right. Everybody that has a migraine regrets not taking their migraine blockers for the last 30 days. You know what I mean? When it hits you, and then realization sets in. Unfortunately, we can't, you can lead a horse to water. You can't make it drink.
Exactly. Yeah.
As someone who has dedicated their life to respiratory medicine, what do you hope your legacy will be in the field?
I just wanted the kids that I saw to grow up to be healthy adults with no limitations, meaning if they wanted to go out, try out for one of the varsity teams, they should not let asthma hold them back. And that was always my philosophy. And even before I could make a firm diagnosis of asthma, I would see an infant, and I always thought to myself, this child has the potential to do or become or be anything they want. And it was my responsibility to ensure that their health didn't impede that achieving that goal. And so I always wanted each child that I saw to maximize their genetic God-given potential. And so, yes, I saw a lot of kids with respiratory symptoms, not necessarily respiratory disease. And that's an important distinction, because sometimes even as a respirologist or pulmonologist, you may see a patient because they're short of breath, but in fact, they have a problem in another organ system, or it's really not their lung that's responsible. And so I always tried to tease that out before I just automatically said, well, this is probably asthma, take this puffer and come back in X number of months.
Yeah. And what you mentioned earlier too, if a kid wants to play sports, they should. Asthma should not be a reason to avoid exercise. Asthma should be a reason to exercise. And I realized that in my adult years now, having ran at this point 3 marathons, I didn't know I was capable of it until I conditioned my lungs, right? We get used to it. We get better. We get stronger. I can go to the mall now, forget to take my inhaler. It's not a huge deal to me anymore. Now as a kid or an adult, even in my 20s and late 20s, that was something I couldn't do. I couldn't walk up a flight of stairs without taking my inhaler, but I trained, I did it properly, and it's only helped me. So I advocate for that as well. I think it's important that we exercise and we don't shy away from it.
Absolutely. And I can probably say with confidence never, because even my nurses would come to me and say, I know what you're going to say, Dr. P, but so-and-so's mother wants a letter excusing their child from PE, phys ed, whatever you want to call it. And I would not write those letters because it was my, I'll say responsibility. It was my obligation to treat the child so that he or she could participate to a level of their satisfaction and comparable to their non-asthmatic classmates. And that was probably the third or fourth goal of treatment. The first one was keep them out of hospital. The second one was keep them out of emerge. The third one was prevent their needing oral corticosteroids. And the fourth was they have to be able to keep up with everybody in their class. Even if they have to take their 2 puffs of bronchodilator beforehand, I want them to participate fully.
Absolutely. That makes incredible sense. And I appreciate that way of kind of looking at it as well. I think we need to see more of that. Unfortunately, growing up, I had doctors say, you need to abstain from exercise because it's just going to make your symptoms worse. And I think now I know that's the wrong thing to be told.
Right.
I did have a guest on episode 5, I believe it was, Maggie McNeil, which is an Olympic swimmer for Team Canada, won gold, silver, bronze, and multiple world records. And she's an asthmatic. And she said for her final question on the episode, her answer was, asthma should not be seen as a challenge. Rather, it should be seen as just another obstacle to overcome. And to me, that was so powerful because we're capable, just like everybody else is. We just have one more obstacle in the way to kind of get over. And once we're over that, it's, the sky's the limit.
I mean, the fact that she was a swimmer is a particular challenge because in my career, there have been 2 populations of athletes, and I was an ex-athlete myself, ran 1 marathon only. That 2 population of athletes that were always a problem. One were the swimmers because indoor chlorinated pools pose a particular problem. And the second was cold air athletes. Now, I retired it from University of Minnesota, where Nordic or cross-country skiing was huge. Cold weather athletes are the other tough nut to crack. And it has to do with the air that they breathe, particularly when they're breathing 10 times above their resting level in order to compete, 10 or more. The changes in air humidity, temperature, and air quality, particularly with the swimmers, is more likely to trigger bronchoconstriction. And so that's an added challenge to that group. The cold air athletes, I played hockey. It was not as good as my son, but I did play hockey. And hockey players are actually easy to manage because their shifts are short. The figure skaters, where the long program is 3.5 minutes, they have to really get their levels of breathing, which we call ventilation, up, and they have to sustain it at that high level for the duration of their program. They were another tough group to crack. And we know that there are some arenas that are, and some pools for that matter, where patients report more symptoms, and it has to do with air quality. I mean, how much air is exchanged per hour to clear out those chemicals in the air that trigger bronchospasm. And so it's a fascinating area. And as an exercise guy, I read this literature. And so, anyway, so your guest really overcame an obstacle being in a chlorinated pool for 4 and 5 hours a day.
So question for you, actually, for myself, I don't have this in the notes, but I'm curious, what's the difference between a pulmonologist and a respirologist?
The country you practiced in. We're called pulmonologists. And in fact, I was certified here as a pediatric pulmonologist, whereas in Canada and in the UK, where I'm also certified, It's called pediatric respirology or pediatric respiratory medicine.
Interesting. So really no difference just based
No
on where you
difference.
live. Okay. So I'd like to move on now to advancements in pediatric pulmonology. We did discuss this a little bit at the beginning, but first question, your research has significantly contributed to our understanding of respiratory physiology. Can you share some of the key advancements in pediatric pulmonology that you're most proud of?
My own personal advancements have not been that remarkable. The biggest advancement in the field was in patients with cystic fibrosis, where now we have a class of drugs that can actually correct a gene defect, which I never thought was possible when I started my career. Now, in the asthma field, it's a little ironic that we've had good drugs to treat asthma since the late 90s, maybe the early part of the new millennium, but it took us 20 years to figure out how best to use them. And I think it's going to take us even longer to convince patients to take them as prescribed, as we said earlier in this podcast. And the innovation in asthma therapy has been the so-called biologics, which are typically synthetic antibodies that target and block some of the key inflammatory mechanisms that cause asthma symptoms. I'm going to digress a little bit because there's a concept that's important to understand. It's called the united airway. And I think the audience will understand things more easily if I describe it. Let's say you have allergic rhinitis, hay fever. You're exposed, you're cutting the grass, and all the pollens are stirring up, and you start to blow your nose and sneeze uncontrollably, and your eyes get watery and itchy. So that's allergic rhinitis in the nose and allergic conjunctivitis in the eyes. And that's because those areas have been bombarded by all these allergens. If your nose is blocked, not a big problem because all you do is you breathe through your mouth. You have an alternate airway. But what happens in asthma is the same reaction in the bronchial tubes that cause the inflammation, the swelling in the nose and the mucus in the nose in allergic rhinitis. In asthma, it occurs in the bronchial tubes or the airways, the lower airways, sort of from the neck down. Now, think about it. You don't have a backup pathway when those airways are blocked. You don't have another channel, another tube that you can breathe through. So when those airways below the neck are constricted, you're really in a jam. And so what you want to do is block the inflammatory reaction that leads to that significant airway narrowing. Now, inhaled corticosteroids are, in a sense, a shotgun approach. They hit multiple pathways, perhaps not effectively as some of the new biologics. And the new biologics target very specific very specific pathways that are involved in this airway swelling, excess mucus, and that leads to airway narrowing. Now, the first one that I was used was called Xolair or omalizumab, and it blocked allergen-mediated inflammation, such as your allergic rhinitis would get better when you were on this drug, but so would your asthma. And that came out 2010, give or take, and it worked great in my experience. There have subsequently been other biologics, benralizumab, mepolizumab, that block a key mediator secreted by the type of white blood cell called the eosinophil that is intimately involved in asthma and allergic rhinitis. Most recently, another project called or Dupixent has come out, and it is effective both in asthma and in eczema. And believe it or not, some forms of eczema are related to asthma. Patients who are started on Dupixent for either condition report that not only the target condition is better, but even their asthma or their eczema has improved once they're on it. And this antibody blocks another pathway, particularly a pathway higher up the chain, and so it has more far-reaching effects. Now, these medications are generally reserved for the more severe asthmatics, meaning you're already on a combination puffer. You may be on 3 inhaled medications. You may be on a leukotriene blocker or leukotriene receptor antagonist, which the most commonly used one is montelukast, and you're still having breakthrough symptoms. Then the next step is a biologic. Now, there have been editorials written saying, well, do we use biologics as first-line therapy? Why would you do that? We already said how most asthma patients, especially the ones who have recurrent symptoms and are frequent flyers in the ER, are probably not taking their medication because it's daily or twice a day, regardless of how they feel. What if we were to give them an injection? That all these biologics are injection only. What if we were to give them an injection once a week, every 2 weeks, or once a month, and it controlled their asthma? Is that a way we should treat asthma? So think about this for a moment. These biologic medications are outrageously expensive, first off, particularly compared to the usual asthma puffers. Secondly, if one were to treat patients with a biologic therapy as first-line therapy, you're actually rewarding bad behavior on the patient's part. They're not taking their puffers as prescribed, and that's why their asthma is such a problem. So would you just go right to a biologic when poor adherence to treatment is the reason? Morally, you would say, sure, give them a biologic. We want to keep them healthy. But with the healthcare systems being what they are, particularly in Canada, you can't have all asthmatics on these biologics. So it's a debate. I don't think we'll get to the point where biologics are first-line therapy. Puffers are becoming cheaper and cheaper as they go generic. Yeah. They're very effective. They've been around for 30 years, even longer, frankly. But the current generation of puffers, let's say, have been around about 30 years, and they're effective. The limitation is you got to get patients to take them as prescribed. Big limitation. It's like having a pick-proof lock on your door. No thieves can get in. The only flaw is the person has to lock the door to ensure
that's right. Yeah, that's right. I heard a saying, locks are only good to keep honest people out. But adherence is huge. I think that's number one. I don't think everybody needs a biologic. No. Myself, when I was 16 years old, Xolair came into play. Unfortunately, my health insurance, Blue Cross, wouldn't cover it. $2,000 a shot every 2 weeks. That's huge. It wasn't feasible for my family. But having that little educational piece, so we talked about, CREs or certified respiratory educators, or CAEs, I think you called them.
Yep.
Yeah. So having one of those to kind of talk to the caregivers, the family members, the patient, and really let them know how big of a difference really adhering to what you should be taking and how you should be taking it. That little educational piece there could have changed my entire upbringing. And again, that's why I advocate the way I do, because I don't think everybody needs to be on biologics. I see they're game changers 100%. I've heard amazing stories from them, but it starts with knowing your illness and realizing too that asthma it's an illness of self-discovery. Unfortunately, we all have our own triggers.
Yeah. Yeah. And it behooves the treating physician or the certified respiratory educator, certified asthma educator, and uncover those triggers or discover those triggers through the medical interview. But the best way to do it is actually for somebody to go do a home visit, and we would send public health nurses to the home, and the information you get there is invaluable. And I will also put in a plug for my time in London at King's College Hospital. When the UK also has the National Health Service. It's government funded, single payer system. And we had a severe asthma clinic there where I worked. And it was invaluable to have a psychologist as part of that team. And I was in practice 27 years when I saw this, that these psychologists will discover things about an individual patient and their family dynamics that I would never even think to ask about in the clinic. And so that's why a multidisciplinary or team approach, your asthma educator, a savvy doctor, and having a psychologist available can really make a difference in these severe asthmatics. And the particular eye-opening lesson that I learned was there was one child about 10 or 11 years old that we knew had severe asthma, but his mother had an anxiety disorder. And this would not report to his mother when symptoms were worsening because they didn't want their mother to become upset or worried by it. And I thought, oh my gosh, I would never have guessed this. And so that's why the patient tries to struggle through until they can no longer do so. And then it becomes an urgent matter. And so having the psychologist as part of the team, as I said, was a real eye-opener for me. And no amount of medication was going to help because the patient would not ask for a lifeline, would not put their hand up, would not call for help because he or she didn't want to upset mommy.
Yeah, you would never guess, right? These patients, they're going through some other things as well. And I guess it's easy to forget when you have a specialization, you're focused on one thing. Having those people there that can connect those dots is incredibly invaluable. And I mean, I think at the end of the day, I mean, maybe I'm biased here. I think it could save the healthcare industry some dollars because I've taken the ambulance X amount of times. I've taken air ambulance X amount of times. I've stayed months in the hospital per year because I didn't have that education there. So again, putting the proper resources in play so that patient and that family could be understood 100%.
Yeah, absolutely. Absolutely.
I'll move on to the next question. The Dalhousie Dyspnea Scales, sorry if I butchered that, developed during your time at the IWK Health Centre have been instrumental in assessing breathlessness in children. What inspired this project and what impact has it had on clinical practice?
So this is going to be a long discussion. Our understanding of shortness of breath, which dyspnea means shortness of breath or breathlessness, is largely hypothetical based on adult models and adult diseases, most notably chronic obstructive lung disease, which in terms is emphysema or chronic bronchitis. It probably is useful in adult patients with congestive heart failure as well, and perhaps with some other less common lung diseases. But breathlessness in children is poorly understood, and everybody assumes that children are small adults, and that's not the case. And the easiest way to understand this is you're not allowed to vote until you reach what's considered the age of majority. And the basis for that is you have to have the mental capacity to sort of weigh the issues and choose a candidate based on his or her positions on those particular issues. So it implies a certain level of cognitive development. Well, that necessity or that need for cognitive development pertains to a lot of other feelings, symptoms, sensations that children experience. One of the parallels is pain, but the big difference is we know babies feel pain. They scream when they get needles, and that one is easier to understand. But when a child feels short of breath, they require a certain level of certain ability to process that information in their brain before they can actually say to their parent or guardian, I'm out of breath. And in fact, we did a community survey here in Minnesota, and for sure, children under 7 and probably preteens is reasonable to assume the most you'll get out of them is I'm tired. They're in PE, they're in phys ed, they can't run as many laps or as fast as their other kids, and they say I'm tired. It's not until their late teens, and the arbitrary age cutoff that we did in our community survey was 18. Kids over 18 were able to say, I get short of breath when I exercise, but younger kids, all they say is they're tired. So that's just an illustration. It was one sample, and we just don't know enough about this in children. But if a child says I'm tired, it may, especially a preteen, they may actually be trying to say I'm out of breath, but their brains just can't articulate what it is they feel. And that's because this whole concept of breathlessness or feeling short of breath has to do more with what areas of the brain are stimulated or activated by the trigger than anything else. So before you got control of your asthma and you would run, you would feel out of breath. Once you got control of your asthma and you started training for the marathon, and I know I've done this, as you increase the miles, you do feel out of breath. That's how you know you're pushing yourself, and you try and run through it. And as somebody who ran a marathon, you realize that this degree of breathlessness or feeling out of breath, tolerable or expected, given, I'm at the 12-mile mark. That's why I'm out of breath. But some patients, a different area of their brain is activated, and their brain perceives this as an unpleasant sensation. When you were running, it was an expected sensation, and so you accepted it, you tolerated it. But if a certain area of the brain is activated, then the patient reports it as unpleasant, and those are the patients that will go to their parent, if they're older, or their doctor, and they'll say things like, I'm tired, or I can't breathe, or I'm short of breath. So there's no quick answer to your question. So because we had poor models of understanding breathlessness or dyspnea in children, I was fortunate enough to work with a noted psychologist who's now an Order of Canada merit awardee, who studied pain in children. And I said to him, Patrick, if we can come up with a picture scale for pain to measure pain in children, why can't we do this for shortness of breath? And so it was just a coincidence that he and I were at the IWK Dalhousie University at the same time, and we got together on this, and we did the work in the late 90s. I finally got it published in 2015, not because I struggled to get it published, but because we had a lot of data and it required a great deal of mathematical analysis, and I couldn't find somebody to do that for me until I was at Mayo Clinic. And then we published 3 or 4 papers on that. And I recently had it made into a web-based computerized program where a patient could size on a bike, do a stress test, whatever, and point to a tablet or touch a tablet and say, this is how I feel. And then I retired, so it hasn't got beyond that stage. I know it was used by a pediatric emergency physician to assess asthma severity in the ER, and this was published probably about 10 years ago, shortly after we published all our papers. I hope it catches on, but it's going to take time.
Looking ahead, what areas of pediatric pulmonology do you believe hold the most promise for future breakthroughs?
It's interesting, Josh. When I started my career, asthma and CF, cystic fibrosis, were the biggest problems, and a lot of research was directed into those. And as I've said in this discussion, we have good treatments for asthma. We just got to get the patient to take them. Treatment of CF has been revolutionized. Now that those two biggest enemies, let's say, have been handled, the community of pediatric respirologists, pulmonologists, are able to look at other problems that we thought were less common. But once you are in the field for a while, you realize they're probably not as uncommon as we previously thought. So the growing populations of pediatric children with lung issues are the infants born prematurely. I mean, we've known since they started ventilating preterm babies that a lot of them end up with a certain lung disease that gets treated like asthma. It sometimes behaves like asthma, but it's not asthma, in my opinion. On top of that, the window of survival has massively crept to earlier and earlier during gestation. So whereas when I started, a 26 or 28 weeker were considered, wow, this child may not make it. Now we're actually treating and keeping alive infants born at 22 to 24 weeks gestation. And remember, a full-term gestation, your 9-month pregnancy is 40 weeks. So yes, we're keeping these babies alive, but at what cost? They have a lot of lung issues, so much so that they often cannot breathe on their own. So they end up having tracheostomies inserted and being mechanically ventilated. And we are now discharging these children home with a ventilator. And the idea is that as their lungs improve, they grow new lungs, healthy lungs. They can gradually take over the task of breathing 24/7 on their own without the aid of the ventilator. And so that's been a big growth area in pediatric pulmonology or pediatric respiratory medicine. And it's going to continue to be one because we're still feeling our way. Can we do it without tracheostomies? If they have tracheostomies, what do we want to do, or what should we be doing to ensure that they're going to breathe just fine off the ventilator and once the tracheostomy is removed? Those are the questions that are at the forefront right now of pediatric pulmonology for the preemies. The other area or condition that we thought was uncommon, but we're finding is more common now that we have better tools to diagnose it, is something called ciliary dyskinesia. And these children have recurrent ear, bronchial, and later in life sinus infections. And they usually show up or are referred because of persistent cough during infancy or early childhood, less often recurrent pneumonia. And we have had to increase our radar sweep, so to speak, when we try and figure out, when we try and understand why a child is having a chronic cough, whether that is a consideration. And the testing for it is a gene test, which is a blood draw, or what's called a bronchial biopsy, which we can obtain easily at bronchoscopy. So those are two areas that we're still sort of working on to improve life for the children, improve our understanding, and obviously improve treatments. Those I would say are the biggest growth areas. Call them that.
So I'd like to move on now to transitioning from pediatric to adult care. Transitioning adolescents with chronic respiratory conditions to adult care is often challenging, I'm sure. What strategies have you found most effective in facilitating this transition?
You know, I saw this question, and the answer is simple. You build up a relationship with the patient during childhood and adolescence. You get to know them as individuals, and then you think, okay, of the adult docs out there who could look after this child, which would be the best fit? And so what I'll do is I'll call that physician personally, or at least send them a direct message. We now have messaging within the electronic medical records, or my least favorite is email, but sometimes I'll even email them, and I'll give them a brief story, and I'll say, you know, I think you're the ideal person to look after this adolescent, and would you be willing to accept him or her? And that's the best way to do it. When I started my career and early in my career, I would typically dictate 2, 3, sometimes 4-page summary of that patient's history from diagnosis until transition. Nowadays, everything's contained in the electronic record, and I can just give the accepting physician a quick, you know, this is the patient with diagnosis, whatever it is, and the main challenges that I've faced in the last 2, 3, 5 years have been such and such. And I just to give them a heads up, because ultimately, I think the accepting physician will form their own opinion, and I'm actually pleased if they sort of change tack and say, Pianosi maybe didn't have it right, or that we could be doing something a little differently. And if the patient is better, no problem. I mean, I'm happy to. That's a time when I don't mind being told I was wrong or I could have done better.
Sometimes good being on the outside looking in and having a new set of eyes on the situation for sure.
Absolutely, yeah.
Definitely easy to get complacent. Is that something that's common, or is that just more of something that you did?
That's something that I did. You know, I don't like emails and I don't like text messages. I like face-to-face conversations, and I try to do that as much as possible, or the closest thing thereof. But that's just my approach. So,
How can healthcare systems better support both patients and providers during this critical period?
wow, that's a loaded question, Josh. It's probably going to take as much time as if we in that way passed already. I've practiced in Canada and the UK, which have the single payer government system, and in the US, which is private insurance. There are problems with both. I don't. I would say that private insurance is better if you get it, but there are a lot of individuals in the U.S. who don't have any insurance, and that's a problem. Whereas in Canada and the UK, everybody had some degree of insurance. So how can the healthcare system? Wow.
We can
There's no simple answer, really. I mean, keep the cost. The simplest answer would be keep the cost of drugs down, one way or the other. That's one message. Yeah, I think applies across the board.
So let's move on now to patient and family education. This one really hits home for me. Educating families is crucial in managing chronic respiratory conditions. What approaches have you found most effective in empowering families with the knowledge and the tools that they need?
So, we've actually addressed most or all of the issues where we can make a difference with the family. First of all, is a home visit, either by a public health nurse or a CAE or a CRE. Secondly, having a psychologist in the team, as part of the team, not for all the asthmatics, but for the frequent flyers, the ones who are in the ER or hospitalized frequently. Have the psychologist interview the child, interview the patient. What are the child's fears or worries? What are the parents' fears or worries? And the psychologists have their own toolbox of questions that to ask and to probe and to try and make an assessment of that child. And I think that's where Western, meaning North America and Western Europe, medicine has failed, is we tend to view the mind and the body as separate. But after I described to you how complex the whole sensation of breathlessness and dyspnea can be, I mean, you need to understand what's going on in the child's mind as well as in their lungs. I know what's going on in their lungs and in their body for the most part, but sometimes I need help to understand what's going on in their mind, and that same professional can explore this issue in the parents and the caregivers, what's going on in their mind.
I think that's incredibly important, because whatever was said to my mom when I was a kid, it didn't always get back to me either. I mean, we were two different people, but having that professional discuss that with me too, they could have gotten something out of me that could have helped as well, because I certainly wasn't hiding anything. I just didn't know what I was supposed to communicate and to whom.
That's right. And they'll know to elicit the answer from you that you don't even think might have been relevant, and you wouldn't normally volunteer that information, but they know what to ask.
How do you tailor your educational strategies to accommodate diverse cultural backgrounds and varying health literacy levels among families?
I saw that question, and at the time of my retirement last December, so only 5 months ago, that was a work in progress. When I worked in the Mayo Clinic, I saw pretty much white individuals. I did volunteer once a month at a clinic for immigrants, whether they were legal or illegal aliens. We didn't ask, but they needed help. In the UK, um, there was a very diverse population, and here in Minnesota, because it's London, England, and here in Minnesota, we have a large Somali and Hmong from Southeast Asia population. So I have been feeling my way to try and understand cultural differences and attitudes when I treat these individuals. And I remember with some patients, I would even ask them, is there a fear or legend that's part of your culture that explains why your child is having all these symptoms? And I would sometimes, not often, and probably not, and for sure not often enough, with the help of an interpreter who is familiar with that culture. The one thing I would say to help a physician address this issue is to have an in-person interpreter with the same background, ideally the same, for the same part of the world, who's familiar with the culture of the patient. And then I would ask them privately or after the visit, is there anything I should know about this particular culture that affects their perception of health and disease, illness and wellness? The trouble was with the pandemic, we had to resort to phone interpreters. And even though the pandemic restrictions have been lifted, phone interpreters are cheaper than having people in place. So now that's become the norm, is you've got a telephone interpreter. And that just is, I mean, it's kind of like almost emailing. You want to be in the room. You want to hear and see body language as well as the spoken word to try and understand what's going on with that particular patient. So it's a challenge. I was still trying to figure it out, and now I'm retired, but I cannot stress enough the importance of an in-person, in-the-room interpreter, and then always have a few minutes afterwards where you can ask that individual, is there anything specific or unique about this family or this particular culture, and how they relate to docs like me, your white middle-aged, arguably older physician.
More experienced, we'll go with that.
More experience, I like that.
Speaking of your retirement, you mentioned you retired in December. So having recently retired, what are you most looking forward to in these new chapters of your life?
Not anything medical. You focus so much to be a good physician. When I say good physician, one who sort of knows that not everybody who coughs or wheezes has asthma. One who knows that, there are disorders that involve other symptoms, other systems besides the lung that can cause lung symptoms. And you want to be able to recognize them. And obviously, you want to be familiar enough with the treatment of some of these non-respiratory conditions that can affect lungs and can affect breathing. And so over the 5 years in active practice, and before that, gosh, I don't know how many years, I have to look back, many years of training for pediatric residency and then pediatric respiratory medicine. I was just so focused on becoming a master in that field that now I'd like to pursue things that I order that always interested me, but I never had time to address.
You absolutely deserve it. And maybe, a suggestion, maybe finding a team that is not the Toronto Maple Leafs to stand by. I could tease you all day. I mean, as we discussed, I'm a Pittsburgh fan, and you are too as well. I mean, some affiliation with the Pittsburgh Penguins, which is amazing. I need to support the home team, so I shouldn't throw them under the bus. But last night was tough.
It was. It's funny, when I was my first year at University of Minnesota, there was a boy from Sudbury who came down for a pancreas transplant, which he got. And I had an extra Leaf jersey, a non-autographed one, that I gave it to him, and I said, "Go home and enjoy it." So
amazing.
yeah. So
For those considering a career in pediatric pulmonology or respirology, what advice would you offer to inspire and guide them?
Don't go in it for the money. It's not a lucrative specialty. Go in it. It's a vocation. You're there because you want to help people, and the irony is that if you're good at what you do, people will come back, will call you, and they may see other doctors, but they'll come back to you and say, Dr. P, this other doctor just doesn't listen, or doesn't explain things as well as you do. So, understand that when somebody says that to you, even though after years it burns you out, it's a compliment, and it's a testimony to the quality of the care you provide. So to balance that off, you have to achieve a good work-life balance, which I really didn't do, but now I'm going to pursue the things that I ignored in my retirement.
Before we wrap up, Dr. Pianosi, is there anything else that you'd like to share with our listeners? Anything that might be important, perhaps upcoming projects? Again, you said that nothing medical is kind of where you're headed. Resources maybe that you recommend, or any final thoughts really in general?
I said this to a parent at the IWK in Halifax. I said, you know your child best. I may know the disease best, but you know your child best. And if you're not getting the answers you want, or you're a little uneasy, find someone who's going to listen and trust your own judgment. So that's for the parents out there.
Self-advocate, not just for yourself, but for your kid as well. So I do have one final question, a question that I ask my guests at the end of each episode. Whether you have asthma or not, every breath we take is a gift, a reminder of our resilience, our drive to keep going, and our power to define our own limits. With a single breath, you have the potential to move mountains and change the world. So with that in mind, again, I have one final question for you. If you had only one last breath, but with it the power to influence the world, what would your message be?
I looked at that one, I thought, oh my gosh, how am I going to respond to that? But ultimately, I said it earlier in the podcast, asthma in particular should not interfere with your goals. And when I say goals, whether it's career goals, unless you want to be a fireman, of course, whether it's you want to play on a varsity team, you have to find a provider who is going to listen to you and is going to tailor the therapy so you can keep up with your peers, and don't settle for, well, this is the best I can do. So just keep plugging and find a doc who will help you realize that goal.
Incredible. Great answer. I love that. The sky's the limit. Again, asthma is just another obstacle to overcome.
Right. So true. So true.
Dr. Pianosi, thank you for sharing your invaluable insights and experiences. Your dedication to pediatric respiratory care and your contributions to research and education have undoubtedly made a lasting impact. To our listeners, if you found today's episode enlightening, please subscribe, share it with those who might benefit, and leave a review. For more information on Dr. Pianosi's work and resources on pediatric respiratory health, please refer to the show notes below. Until next time, keep pushing forward, breathe deeply, and remember the strength within each breath. Thank you for listening to Beyond the Wheeze. If you enjoyed this episode, don't forget to subscribe and share. Follow us on Instagram at Beyond the Wheeze, or follow me at the Asthma Runner for more updates. Keep breathing strong, and remember, your potential has no limits. Until next time.